Hello, I am Dr. Ankit Sharma. I am working as an assistant professor in Government Medical College, Raipur. And today we have a great topic which we'll be discussing with a very great surgeon, Dr. Banerjee sir. Welcome sir.
Thank
are
you,
here
Dr.
with us.
Sharma.
So today we'll be discussing about Parkinson disease, and Dr. Banerjee is specialized in movement disorders and especially in deep brain surgery, sir. So, sir, as a doctor or as a physician or as a practitioner,
Yes.
what is the earlier signs and symptoms of Parkinson disease, sir?
Right. Good question, Dr. Sharma. I am Dr. Anirban Deep Banerjee. I am Director Neurosurgery, Medanta Hospital, Gurugram, Delhi NCR. So, Parkinson's disease is it's not a rare disease. It's like not an uncommon disease, but it's often neglected disease because of lack of general awareness towards how to pick it up early. And if we pick it up, then what next?
What next?
So, there are certain early signs of Parkinson's, like Parkinson's signs and symptoms. मोटे तौर पे you can divide into two groups. One is motor symptoms, one is non-motor symptoms. Motor symptoms are the one which come, which are more noticeable. But that's just the tip of the iceberg. There's a huge spectrum of symptoms in Parkinson's which are non-motor, which are equally important to pick up. So, there are certain early signs or subtle signs of Parkinson's even before the motor symptoms set in. Like, patient can have a sudden onset difficulty in smelling properly. Like recent onset constipation. Patient never had constipation in his life. Recent onset constipation. A bout of depression. Without any, associated reason, so to say. Or, nightmares. Nightmares, like bolt from the blue, patient has started complaining of nightmares, say, for the last 15-20 days. Severe nightmares. So, these are the subtle signs which creep in. And they are often neglected. I mean, who will notice the importance?
Yes, sir. Usually we see or we read about Parkinson's as motor symptoms only. So, these are the symptoms which are slight and which initiate those diseases, sir.
Exactly.
So, we should first find those things and initially we should treat those patients.
Exactly. So, if a patient develops one or more of these symptoms, then he or she should consult his or her physicians. And if the physician has even an iota of doubt, he should refer to a specialist doctor to rule out whether it's not necessarily it will be Parkinson's. But it's always better to rule out at an early stage by a neurologist. So that if it is picked up early, then the management of the disease becomes that much more easier.
So, sir, as a physician, what I do is I'll see the patient of Parkinson. I see that there is a bradykinesia or some other symptoms are there, and I'll treat those patients with medicines. But exactly at what time, at what point of time we should send such patient for DBS surgeries, sir? When is the time, sir, or which all things we should strike that this is the point where we have to send, sir?
So, very poignant question, very important question. So, yes, so suppose the patient comes with frank motor symptoms to you, and you detect that he has resting tremors, kampan hai haathon mein, akran dhimapan hai, rigidity, bradykinesia. You try to improve his symptoms, improve his quality of life with medications as the first line of therapy. Combined with structured, exercise regime, at least 1 hour of low impact exercise per day. But after a few years, say on an average 5 to 7 years, the medication starts losing its efficaciousness. And to add insult to injury, there are some side effects which can crop up. For example, the syndopa medicine in Parkinson's, commonly used, can lead to dyskinesias, which are a set of abnormal movements which further cripple the patient down. Or patients can have intractable hallucinations with other dopaminergic medication. These are a few examples of those side effects. So, if the patient's that response to the medications decline with time, or the side effects of the medications are so much so that patient is non-compliant to the medication because of the side effects. So these are the broad things. But the question which you put is when to know that we have to opt for an advanced therapy and go beyond medications. So officially, formally, so to say, if you want to do it, it's a multidisciplinary approach. There will be a board of doctors comprising a movement disorder clinic where they will evaluate the candidature of the patient in terms of the structural neurological problem as well as the functional faculties. For example, in the from the neurological point of view, usually we do an UPDRS scoring.
Okay.
Unified Parkinson's Disease Rating Score, MOTOR, UPDRS 3 scoring. In off score, where you stop the medications for 12 hours and then after giving a levodopa challenge, where you do it in on. So there should be a difference of at least 25 to 30% in that between the two scores. This is one example. Then there should be a detailed neuropsychological assessment to rule out dementia, which is an absolute contraindication. So this comes as a structured evaluation. But there is also a screening tool. Like someone comes to you with Parkinson, you have been treating that patient for a few years now, but now his medications are not working that well and he is developing side effects. So there is a simple screening tool which can be applied to have a prima facie idea that the disease has progressed to an advanced stage and it will need some advanced therapy for that. So the rules is known as the 5-2-1 rule.
5-2-1.
So what is 5? The indicator 5 is at the patient's daily requirement of anti-Parkinsonian medication. For example, Sendopa. It's at least 5 doses or more.
5 doses or more.
2 is, despite the optimization of these medications, the patients have at least 2 hours of off time during the day. Okay. Despite appropriate medications. Off time means his activity is totally retarded in spite of taking medication, and the duration is more than 2 hours.
Okay, sir.
And one indicator is the side effects, for example, dyskinesia. The duration of the side effect or dyskinesia is more than 1 hour in a day. So 5 or more doses, 2 or more hours of off time, and 1 or more hour of side effect or dyskinesia. So any one of the factors indicates advanced. So 1 or more, if they are positive, then you know that the medications and the physical therapy they are not sufficient. So you have to explore advanced treatment options. For example, deep brain stimulation surgery or brain pacemaker surgery.
So very important point said by sir is we have to remember about, as a physician, we have to remember about 5-2-1. So these things sir has in detail sir has told. So next thing sir, we are commonly knowing about, everyone is knowing about pacemakers. Cardiac pacemakers everyone knows that some leads are placed, and each and every corner of every tier 2, tier 3 cities we are seeing that cardiac pacemakers are being used.
Yes.
So in detail sir about brain pacemaker sir, what is that pacemaker sir, where leads are kept, where batteries will be placed, and what things we are doing in pacemaker sir.
Yes. So as you rightly told, the philosophy is the same. Like in cardiac patients, in a particular cohort, when the medications are not sufficient any longer, then you have a heart pacemaker to maintain the rhythm of the heart. Similarly, when in certain neurological or psychiatric diseases, for example Parkinson's disease, dystonia, essential tremor, adult onset partial onset epilepsy, or OCD, obsessive compulsive disorder. These are the 5 indications which are approved as of now. So when medications lose their efficaciousness, they become refractory, the disease becomes advanced and refractory, then you have to put a neuromodulation device, what we call as a brain pacemaker or deep brain stimulation device, whereby you implant 2 slender wires deep inside the brain at a specific target, which controls that particular disease, which varies from disease to disease. For example, in Parkinson's, so the commonest target is your subthalamic nucleus. For say dystonia, the commonest target is the globus pallidus internus. For essential tremor, you have the ventral intermedius nucleus of thalamus. For intractable epilepsy, you have the anterior nucleus of thalamus. And for OCD, you have the nucleus accumbens. So these targets vary depending on the disease. So you stimulate that area, and due to electrical stimulation or neuromodulation of that particular part of the brain, the coordination of the neurons are reset. And resultantly, the symptoms reduce. The quality of life improves. It's a very simple philosophy. If we can give a simile to that, for example, on this table you strew some iron nails. They will be all over. Now you put a magnet there. All those nails will be aligned with the magnetic field. They get into coordination. Similarly, when you implant those electrical conduits, those electrodes deep inside the brain at one specific target, and set a microelectric stimulation, it creates a magnetic field. And that leads to, in simple terms we are discussing, like that leads to resetting of the coordination in terms of the transmission between the neurons. And once that coordination is slowly reset, the abnormal symptoms due to the pathological circuits, they tend to reduce. There will be for example, in Parkinson, there will be a steady decline in shaking of the hands. There will be an improvement in terms of the slowness, and there will be reduction in the stiffness. And gradually, with the conglomeration of these improvement, patients walking and other daily activities should improve with time.
So, with DBS, sir, you are telling that it is a complete resolution of those symptoms, or with time it will come, or some gaps will be there? Sir?
Yes. So, it depends on the symptom. If it's a shaking or tremors, so it's almost always, we as doctors never say 100%.
100%.
So it's around 80 to 90% improvement, which is good enough for the patient.
Good number, sir.
Yeah.
It's a good number.
For stiffness, slowness, around 60 to 70%. But for stiffness and slowness and improvement in the walking, it grows with time. The shaking improvement is instantaneous. The walking improvement takes time. We have to add some structured gait training and all that to expedite the improvement.
So overall, patients' day-to-day life will be improved.
Yes.
Somewhat improved.
Yes.
Better than earlier.
Yes. In well selected. That's why we spend a lot of time in selecting the right patient. Patient who qualifies through the movement disorder clinic checks all the boxes. If the patient selection is good, the rest of the things, they fall in place.
So, sir, if a patient comes to you for deep brain stimulation surgery, sir, so any contraindication, or when we have to send for follow-ups, or when we have to change those leads or those batteries, sir?
Yes.
Any idea about those?
Yes. So there are various aspects to your question. The only absolute contraindication is dementia. The patient has severe dementia. Our neuropsychologist or neuropsychiatrist documents that he has, frank dementia. So then we should not do DBS in that. Secondly, we have to rule out the Parkinson's plus syndrome. There are various mimickers of Parkinson's. So in a movement disorder clinic, there should be a thorough assessment to rule out diseases like progressive supranuclear palsy, multisystem atrophy, and so on and so forth. Because if you do wrongly, by mistake, do DBS in those patients, then there will be a rapid, instead of helping the patient out, there will be a rapid decline. It is seen. So those should be ruled out. So these are certain, contraindications. Rather, these are certain screening techniques or modes you should apply before certifying that the patient will needs DBS. Second is your question was that follow-up. So that's the USP of DBS, because all these diseases, especially Parkinson, they are all progressive diseases. So it's not a one and done therapy. If you have done the surgery, you have to follow up by regular programming sessions whereby you fine tune the battery, maybe tweak a bit of the stimulation in terms of the parameters, the amplitude, pulse width, hertz, the contacts you can modify with time, so that you can always stay one step ahead of the progression of the disease. So initial 3 months, 1 or 2 times the patient need to come for to reach a plateau in terms of proper thresholds for stimulation. And then after that, at least twice a year, he should be there.
So, sir, as a physician, if I am sending you the patient, so that candidate should be a apt candidate. So, what are the prerequisite or pre-follow-up investigation or prerequisite which I have to see, sir, as a physician or as a practitioner, I should see, sir, which you want there and patients have to have there?
Yeah. So, when you have through primary basic screening, you feel that the patient has advanced and you will need to explore further therapy. So you refer to a specialist center, and all those investigations are done after the patient is seen there. The only thing is, suppose the patient qualifies to be a to be a good candidate for deep brain stimulation surgery, and most of these patients are in the geriatric population. They will have comorbidities, so they should have a strict control of diabetes. The blood thinner should be stopped at least 1 week prior to the procedure. These are certain basic common things which I am sure any practitioner will have the know-how about. But the hardcore investigation and delving deep into the candidature of the patient is done by specialist institutes. But if you have a prima facie evidence through those screening tools, for example, the 5-2-1 rule, then it will be wise to refer them for further investigation to a specialist center.
Okay. So, sir, in your hospital, sir, Medanta, how you are approaching those patients once patient goes from here to your center, sir?
So, we have a movement disorder clinic. We ascertain the candidature of the patient in a multidisciplinary approach, and once the patient is given the green signal, when the consensus is that patient will improve, then we admit the patient after counseling him the pros and cons and the various logistical issues that the patient need to understand. We admit the patient agrees to all the aspects. We take an informed consent, like admit the patient, say for example, if the patient is admitted today, the next day we do a DBS protocol MRI, special MRI under sedation. The following day is the procedure, whereby we take the help of a GPS-like device, what we call as a stereotactic frame, fit it to the patient's head and get the necessary imaging and various fusion techniques with CT and MRI, and with the help of the computer, we implant 2 electrodes, one on each side of the brain, depending on the disease, the targets vary. And we connect the wires with a pacemaker, all internally, nothing is visible from outside. And within 1 or 2 days, usually 2 days after the procedure, we discharge the patient. And then he follows up as we discussed for the programming sessions. The stitch removal is usually on the 10th day. Till that time, the dressing needs to be done every alternate day.
Thank you, sir.
Thank you.
So, it's an honor that you told us about deep brain stimulation surgery, sir, in a very detailed way, and it will be very helpful for us as a practitioner, that which patient selection should be done, how we have to send, or which all precautions we have to take, sir. So, for Parkinson disease, it is most important that we should see those early symptoms, and it is very important for caregivers also, sir, for family members also, that they should also understand that these are the early symptoms which earlier they were neglecting those patients or those symptoms, sir. So these things will have, and other than medications for practitioners, there are a lot of advancements going on, especially deep brain stimulation surgery, sir. Hopefully, we will be sending you some patients, sir, and we will be helping those patients also, sir. Thank you, sir.
Thank you, Dr. Sharma. Thank you.